So this is just a short screencast around objective assessment. So I'm just going to talk you through the presentation, so please feel free to pause at any point. Okay, so when we're looking and observing somebody, the objective assessment is what we see. So subjective is what we gain from the patient, so what they say to us, whereas the objective assessment is what we see on the patient. So when we're observing and looking at somebody, we need to make sure they're in a suitable state of undress, so you can see the limb, or you can see the spine, or you can see the issue that they've come to see you with. So you need to make sure that they have their socks and shoes off if appropriate, and you need to make sure that they have the limb uncovered. So for example, if you're looking at the knee, you need to make sure that you're looking at both left and right, so they've uncovered both. They have removed both socks and shoes, and obviously you're looking at it from all angles. So you look at it from posterior, looking at it anteriorly, and looking at it laterally, so you're moving from side to side. You're observing for posture. How is that patient standing? The muscle bulk. Is there any signs of hypertrophy or atrophy of the muscles? Movement patterning. So having a look at how they move, how they do functional movements, such as sit to stands, squats, lunges. What's their gait pattern like? How are they walking? Is there evidence of a limp? Is there evidence of trying to offload that side? You're looking and feeling for heat. So when you're feeling for heat, you're using the back of your hand. Sometimes heat is often associated with redness. So you're looking for any redness around the limb or around the area. Heat and redness together would be indicative of there being some degree of infection underlying, or there being some degree of underlying inflammatory response. Is there any swelling? Thinking about when they had the injury, is it an acute injury? What state of repair is that limb in? And is there any bruising? Has there been an external trauma or an external force? If there hasn't been an external force and there is bruising, what potential underlying structures could have caused a bleed to have caused bruising? Thinking about the active range of movement. So active range of movement, again, if we go with the knee, thinking about looking above and below. So sometimes you can get referred pain, so pain that doesn't necessarily come from the knee. Sometimes you can get pain that's referred from the hip or referred from the spine. You may also get referred pain due to the fact that the patient is offloading. So you might get left knee pain because the patient is offloading the right hip. So thinking about the active range of movement at the hip, the knee, and the ankle. What is the movement quality? Can they do it nice and smoothly and easily? Is it painful that's limiting the movement? Is it the fact that there is crepitus or a jerky movement? Are they weak so they don't have good movement quality? What range of movement are they getting? So here you're thinking about your normal movement ranges, and you're being able to identify right versus left, and also thinking about the limiting factors. So what would be the end range? What would be the limiting factor for, say, knee flexion? And if possible, you'd use a goniometer. Goniometry is something that we will cover in more detail when we get a chance to get you face to face. So thinking about how you use a goniometer, and it might be worth pausing here to have a think about the goniometer itself and the ranges of movement that are available in the upper limb and the lower limb. Palpation. So then we'd have a feel. We'd have a feel of the range of movement, so as the joint is moving. So thinking about when we're moving that knee, is there any clicking? Is there any grinding? When we're moving, does it make swelling move around? Does it make the swelling bigger or less when we start to move it? When we're using passive range of movement, so when we're providing passive range of movement, does that change the patient's pain? And if it does change the patient's pain when they're doing it actively versus passively, what does that indicate? What structures might that mean are being affected? When we're doing passive range of movement, we're using overpressure. So we're feeling the end feel of the joint. We're feeling for any issues with resistance or lack of resistance potentially. What does that indicate? What other structures could be going on if there was a lack of an end feel? We're looking at muscle strength. So once we've looked at active range of movement, we've had a feel, we've looked at passive range of movement, we might have had a look at active assisted range of movement, whereby we might take the weight of the limb while the patient does some active range of movement. When we come to look at muscle strength, we're thinking about the type of muscle contraction we're looking for. Is it isometric, concentric, or eccentric? Are we looking at functional muscle strength, so things like sit-to-stands or squats or potentially lunges? Are we testing that muscle strength in the inner, mid, and outer range? And then just pause here as well and think about where would be the strongest contraction of a muscle. Would it be in the inner range, the mid range, or the outer range? And why would that be? So here what I want you to do is pause the presentation and have a think about what makes up a muscle. What's the underlying physiology of a muscle, and think about why potentially the muscle strength would be different in the inner, mid, and outer range. And I want you to delve into the pathology of muscle contraction and of muscle strength. So I just want you to write a short half a side of A4 about what is a muscle and what affects muscle contraction. So once you've done that, I want you to have a look at the Oxford scale, which is shown on the right hand side of this PowerPoint here. So the Oxford scale is generally used to measure muscle strength rudimentarily in clinic, and it goes from 0 to 5. And going from 0 to 5, it's a numerical scale looking at how much strength there is within a muscle. So 0 would be no contraction at all. 1 would be a flicker of contraction. 2 would be full range of movement, but with gravity eliminated. 3 would be full range of movement against gravity. 4 is full range of movement against gravity with some resistance. And 5 is muscle functioning normally. When we're looking at muscle strength, when we're looking at the muscle range of movement, we're looking at it through range. So we're looking at inner, mid, and outer range. So neurological assessment. So once we've done that, we might want to have a look from a neurological point of view. So we're looking at the reflexes of the upper limb and the lower limb, looking at the dermatomes and looking at the myotomes. So dermatomes are looking at skin sensation and myotomes are looking at muscle contraction. Myotomes are important when looking at whether there has been any weakness. So when you're looking at muscle weakness, you might then want to have a think about whether or not that follows a myotomal pattern. So is it the fact that they have lost knee extension and knee flexion, and which levels does that affect? We'll cover this in more detail further down in your course, but it might be worth just pausing here and having a look at myotomes, dermatomes, and reflexes for the upper limb and the lower limb. Special tests. So there's various special tests depending on which joint you're looking at. So there's very special tests for the knee and the elbow. So if we think about the knee, because we're following on that same pathway, special tests for the knee would be to have a think about when we're looking at potential cartilage problems, we're thinking about McMurray's and Thessaly's tests, or if we're thinking about potentially there being a ligamentous problem, we're thinking about the SAG test or the horizon test for PCL, thinking about Lachman's and the anterior draw test potentially for ACL. What I would like you to do here is just make a short note of any special tests that you can find in relation to the elbow, the knee, the ankle, the hip and the shoulder, and any non-specific tests that you might come across that don't really fall into a category of a particular joint. So when we're doing an assessment, our subjective assessment always guides our objective. You will always find physios that will say that they have some degree, probably about 90% assurance of what is going on with their patient just from what the patient has said from the subjective assessment. So if they're saying that they have pain within their knee, we obviously know to have a look down towards the knee. Bearing in mind what they've said in terms of trauma, has it been a twisting injury? If they've had a twisting injury, then we're highly suspicious of there being a ligamentous problem. If they give us ideas around there being clicking or popping or giving way, then that gives us an indication to look further into meniscus. So you can see how the subjective can feed into our objective assessment. We're always checking above and below. We're thinking about red flags. So thinking about the red flags, I just want you to recap briefly here what the red flags are. Now, not just red flags for spinal, but also red flags for things like cancer. What would be a red flag if a patient said it that would need further investigation? And then the neuro assessment. So going back over your reflexes, dermatomes and myotomes for the neuro assessment. I want you to take a moment to go back to the case studies that we used in the subjective assessment. And I want you to have a think about, based on the subjective assessment that's described, what are we thinking about objectively? I want you to think about what you would want to have a look at for each patient for each of the case studies. So thinking about the knee again, so possible structures of the knee. So you're doing a lot of detective work. So you're trying to rule things in or rule things out with questioning. So like I said before, if somebody complains of giving way or clicking or locking of the knee, then if they're saying then yes, then you're ruling in a meniscal problem. If they're saying they don't have clicking or locking or giving way of the knee, then you're ruling out a meniscal problem. If they have absence of trauma, so they've not had a twisted injury, they've not had a fall, they've not had a sporting injury, then you're ruling out to some degree ligamentous problems because they've not had a trauma that would cause a ligament problem. Whereas if it's come on gradually and the pain is worse on a morning and is lasting with stiffness for longer than 30 minutes, you're then starting to rule in osteoarthritis. Then you can look at if somebody has decided to do imaging, so x-rays or MRI scans, you can then support your working diagnosis with the imaging. It's important to remember that imaging is not always primary, and we would not always ask for imaging. We're trying to reduce the amount of imaging that we do within the NHS because it doesn't necessarily inform our pathway or change our treatment plan. So thinking about clinical reasoning, there's only so many things that can be going on. So is it neurogenic? Is it nerve? So what can you come up with any questions that would rule in or rule out there being a nerve problem? Osteogenic, so is it bony? So can you come up with any questions that would rule in or out bony problems? Chondrogenic, is it the joint itself? Is there anything that you can do to rule in chondrogenic problems? And is there any questions that you can come up with that would rule that in or rule that out? Myogenic, so is it muscular? So what questions could rule in or out muscular problems? Or what objective assessment could you do to rule out or rule in myogenic problems versus osteogenic problems? Is it vascular? What could indicate a vascular problem? Ligamentous, is there any history that would indicate there being a ligamentous problem? And what could you ask your patient, or what could you test with your patient, or what could you use to indicate whether or not it's a ligamentous problem? The same with bursitis and capsular problems. So have a think here. If you had a 38-year-old with medial knee pain for a week, what would be your working diagnosis? If you had a 38-year-old with medial knee pain for 2 years, what would be your working diagnosis here? Same with a 68-year-old with medial knee pain for a week, what would be your working diagnosis? Or a 68-year-old with medial knee pain for 2 years? And then if you're thinking about a 15-year-old with medial knee pain for a week and a 15-year-old with medial knee pain for 2 years, what difference does the age make? What difference does the acuteness of the problem make? And just have a think about how your working diagnosis would change depending on those very limited factors. So by the end of this presentation, you should have been able to have a look at reflexes, dermatomes and myotomes very briefly. You should have an idea of what you're looking for in an objective assessment and have come up with some questions that would rule out your clinical reasoning or rule in your clinical reasoning. We will tie this together in your objective assessment webinar.